Welcome to Humanley, the podcast providing allied health and integrative medicine practitioners with the most up-to-date, evidence-based and clinically relevant information. Here's your host, Daniel Reuters.
Hello and welcome to the Humanley podcast. My name is Daniel Reuters and today I'm joined by Associate Professor Teresa Mitchell-Paterson. Thank you so much for coming along, Teresa.
You're welcome, Dan.
Really great to have you here. Before we get started, most people are probably familiar with your work, but for those that don't know you, would you be able to provide a bit of background about what you do?
Yes, absolutely. So, many years ago, I think I had something like chronic fatigue before chronic fatigue was ever even heard of. And I was about 18 years of age, living in London. Went to the doctor who decided to give me some Valium because he thought it was all in my head. So I didn't take to that too well. And I decided to visit a natural therapist and kind of got hooked on it. But I'd like to say that prior to that, my mum was a herbalist. So she would take us out in the fields and we would pick flowering chamomile heads and stinging nettles and go wild crafting for nuts and seeds and all sorts of things. So there was always a background of natural health in my past. So I started off my career as a massage therapist. And surprisingly, in those days, you didn't even learn anatomy and physiology. So that just goes to show how long ago that was. And I wanted to do something that was more integrative, something that would be more long-lasting than massage therapy. So I started off as a herbalist. And from there, I did clinical nutrition, then naturopathy, and then eventually did the Bachelor of Health Science and Masters of Health Science, and so on. And currently starting off on my PhD journey. But all along, I have been in clinical practice and I've really enjoyed those years. And I really don't see my position as a natural therapist as a job. There's not one day that goes by that I'm not vitally interested in what I do.
And that's really refreshing to hear, Teresa, because some people burn out after being in a profession for a number of years, but you've been in the natural therapy space for quite a number of years.
Yes, it's coming up to 30 years. Actually, it's a little bit longer than that, so it's quite some time. But, it's evolved over the time. So, it hasn't just been in clinical practice. It's, been in media, it's been in writing, it's been in curriculum development for natural therapy. So there's lots of varied arms to what I do. And I think that's what keeps the interest going.
And one of those things that you're actually doing is acting as a spokesperson for Bowel Cancer Australia. Do you mind sort of touching on how you got involved with them and what drew you to actually become the spokesperson for?
Yes. So, look, I've always been interested in the biochemical pathway of cancer. So just to go right back to my early clinical days, I was fortunate enough to spend 3 years as an intern with a fellow of ANTA at the time. So you can imagine naturopathy in those days was, we thinking it was quite new, but it actually wasn't. So she'd been a naturopath for about 20 years already. And those first formative years, the first 3 years as I was studying and being an intern, my mentor was practicing in a clinic that saw quite a few cancer patients. And then later, my dad got bowel cancer. And leading up to his diagnosis, he had chronic ulcerative colitis, which we know is a risk factor. And my sister and I really tried to help my dad with natural therapies. But, at that stage, he was a little bit too far gone. And I don't think I really had a firm grasp on the pathophysiology of the disease at the time. So he did battle through bowel cancer, and he lived the last 20 years of his life with an external bag, which is also known as a stoma. This did save his life, but he just didn't know how to manage it. So that's been a big driver for me, because I do talk to a lot of patients who have had surgery on their bowel, and this is a really tricky area to manage in terms of nutrition and sometimes supplements, because that bag has got a mind of its own. And one of my patients calls her bag haggis. And yeah, I know. And she writes the most funny stories about it, because that bag can overflow, it can burst, it can smell, it can have a tragic amount of trauma around it. So I was very interested in that. And then I was asked to go and work in the mining industry, believe it or not, by one of my ex-students who was a nurse. And she was at the same time working with Bowel Cancer Australia, setting up a nurse advisory service for Bowel Cancer Australia. And when I told her about my history, she approached the CEO at the time, and he thought it would be a great idea to have a nutritionist on board. And that's how I managed to start off my advocacy for Bowel Cancer Australia.
And how long have you been the spokesperson for them now?
10 years now. So it's coming up to my 10th birthday. So
that's fantastic. And I'm sure lots has changed since you first got involved with them. So in regards to nutrition, what would you say has been the biggest sort of development, or what progress have you sort of seen since starting with Bowel Cancer Australia?
Well, I don't think a lot has changed. You'd like to think it has. I think one of my biggest bugbears is that about 70% of people that come out of bowel surgery don't get dietary advice. And
that right?
Yes, and that hasn't changed. And 90% of those people that are asked about diet and lifestyle advice would really like to have something to walk away with. So I'm not saying everybody, but from the research, it's about 90% of the patients would really want something, because it's a tricky area to negotiate. And
that's incredible that they're not getting nutritional advice.
I don't think it's unusual. I think you will find that, we would think as natural therapists that would be par for the course. You have a chunk of an organ that is involved with the absorption of nutrients, the manufacture of nutrients, the stabilization of microbiome, and the ability to defecate without embarrassment. You would imagine that there'd be some kind of program for that, but there isn't. And I also think that, you get similar situations with other diseases, although I don't know the statistics on those.
I'm absolutely blown away by that. I would have thought nutrition would be the sort of one of the major or main focuses for someone who's gone through bowel cancer treatment. Do you think that's going to change? Is there anything that you know of?
Well, that's why I'm doing a PhD on it, basically. That's why I'm heading towards that PhD, because eventually, obviously it's going to take time, but eventually what I'd like to highlight through the research is that we really need to be changing policy at point of care for these people, because it's so traumatic.
So the PhD that you're starting, or you've recently started that, can you tell me a little bit more about what your research topic is?
Yes, so most people study high fiber, and I'm actually studying low fiber. So it's counterintuitive, I guess, to be eating a low fiber diet when you're experiencing a disease such as cancer, because we know that low fiber diets potentially can be quite high in sugar. And so, and simple carbohydrates. So we tend to steer away from it. But if you are talking about a patient that has had rectal surgery or has a high output stoma, which means lots of fecal output, sometimes as much as 30 times a day, and or they've had a reversal, then what you need temporarily is a low fiber diet. And you need to be able to look at that low fiber diet and make it as healthy as possible, as nutritious as possible, and to fit in with a lifestyle that means some simple swaps, and not try to overwhelm a patient that's been A, diagnosed with a potentially lethal disease, and B, is struggling with the fact that their appearance has changed.
So when you're talking low fiber, are we sort of talking 5 grams, 10 grams a day?
We're talking 10 grams a day, and it varies. So this is really why you need either a dietitian or a nutritionist to manage this. So you do need to plug food into a software program, but one of the best places to look, so this is for all the prackies out there, is on the USDA database and or on our FSANZ database in our nutrients, and to look at just to plug in foods that have fiber. And then you'll come up with a long list of foods that have fiber, starting from the lowest amount of fiber to the highest amount of fiber. And you just go through those lists, and you put together a list of foods that have got high antioxidant profiles but are traditionally low in fiber. And sometimes you have to go to a sort of a clear liquid diet, depending on whether or not there's a bit of a flare-up of stomal or fecal output, and then go back to the 10 grams. And then after that, you slowly progress as time goes on. And as the surgery starts to heal and the nerves reattach, and we all know that nerves don't heal that well and can take up to 2 years to actually get to their final resting point. So it can take that long to get back up to a reasonable amount of fiber.
And what sort of, you mentioned like high antioxidant, low fiber foods for people, things like broths and things. Are there any other foods that you typically use in clinic?
Yes, so most people think they can't have vegetables, and that's not the case. So, baby spinach without its stalk is a low fiber diet. And it's a low fiber food, and spinach can go in lots of things. It has to be the baby spinach because we don't want any stalks. Green beans, most people would think they're high in fiber, but they're not. They're low in fiber. And tomatoes that are pureed, that have their skins and seeds removed. Radishes are low in fiber. Carrots are low in fiber. And then you look at some of the berries, and you may not be able to eat the skins of berries, but you can always have the pureed berries. And apples, as an example, red apples are fantastic for stomal and high output bowel conditions. Yogurt, of course, fabulous food. Eggs are great. Tofu, scrambled tofu is a fabulous food for stomal patients. And if you eat cheese or cheese, which is the the coconut version of cheese, then, there's lots of foods that you can include in a low fiber diet that's really beneficial. I like to include organic organ meat, because of its high nutritional content. It's not everybody's cup of tea, but highly beneficial.
And how soon after surgery are you starting this diet? Is it something that you do straight away? And how long would you get them to do that particular diet for?
That is an unknown. So some people can come straight out of surgery and eat a normal diet. I don't hear about those people, Dan, because obviously my position is listening to people who are having problems. So I'm sure there's a percentage of people that can just come out and just eat a normal diet and not have any problems at all. Some people can start including fiber after a couple of weeks, some a couple of months, some a couple of years, and some never.
Yeah, it's not something that I've actually ever really considered, going for a really low fiber diet in the management of bowel cancer, because so often we're all discussing the benefits of high fiber, but I guess that would sort of be more from like a prevention standpoint, wouldn't it?
Correct. And, the other thing is you have to remember that with a shortened bowel, fiber can get stuck. So the opposite of having high output is a bowel obstruction. So we use a low fiber diet, and this is where most people get a bit confused. We use a low fiber diet in high output and also in bowel obstruction, because it moves through the digestive system without blocking it. Whereas if you suddenly put in, let's say, 2 tablespoons of psyllium husk, because you think it's a good idea for a bowel cancer patient, you can actually block the bowel and people end up in hospital.
It's a really important consideration, and I'm sure many practitioners listening to this wouldn't actually be aware of that.
Well, it sits in other areas as well. So it also sits in flare-ups for ulcerative colitis. It sits in flare-ups for Crohn's disease. And it sits in the area of diarrheal episodes. So, there are a number of reasons why we need to, as practitioners, understand the low fiber diet. It's not a permanent diet, but it's certainly a very good diet to understand for flare-ups and post-surgery.
Now, of that 10 grams per day that you were mentioning people post-surgery would be eating, are there any particular types of fiber? Does it really matter what the fiber is, or it can constitute a range of fibers?
It does. So, and this is getting, but it gets a bit, not technical, but a bit sort of, so if a person has sticky poo, we call it sticky poo, or the poo doesn't come out properly and go into the bag, this is called pancaking, which can be extremely embarrassing. You have to add fiber, but it's the type of fiber that matters. So if you want to bind all that material together and you want it to come out more like a sausage, which is what we expect everybody to have a nice sausage poo, you need a soluble fiber, mostly a soluble fiber, and resistant starches. So those are the types of the fiber that you need, not the itchy, scratchy stuff that you find in, the bran. You want the seed that includes the bran plus the mucilaginous component of the seed.
Yeah, interesting. Really, really interesting. And for that particular fiber, when you're going on a lower fiber diet, do you modify their water intake accordingly as well?
Yes. Yeah.
Yeah.
So, it is interesting how many people don't get enough fluid. And because we don't have the capability to recognize when we're dehydrated, the majority of us don't know and wouldn't think to look at the color of our urine, or don't understand that if you've got, very brightly colored or orangey colored urine, then you're definitely dehydrated. If you don't know that, then you can be quite tempted to have, 3 cups of tea and think that's okay. So, you do need to make sure that people have plenty of fluid with their fiber, of course. And I think the other key point there is to make sure that people understand that when you introduce fiber into the diet, you've got to go slowly. So when I say slowly, I mean like half a teaspoon of fiber for a couple of days. See how the bowel reacts to it. And then you might go up to 1 teaspoon for a couple of days until you get to your threshold.
And is that something that you've been perfecting in clinic over the last several years, or is that?
It certainly is. So, and particularly with Bowel Cancer Australia, I'm able to talk to people twice a week. So I will set them off on that path, and then I'll ring them in a couple of days and say, how are you going? Is this working for you? What else do we need to do? And then monitor that over a couple of weeks. And then once they get to their threshold, they can merrily go on their way.
And for most of the people that you're seeing with bowel cancer, what's the general age range? Are they older people, younger people, a mix of both?
Well, it does tend to be more of an older person's disease, but it's typically happening in younger people, sadly. There's been a 186% rise in people 24 to 29 years of age with colorectal cancer compared to people born in the 50s. And it is also the most common cause of death in people in that age bracket. So
in that 24 to
29.
29, it's increased 186%.
Yes.
That's incredible because I've always thought of bowel cancer to be
an
something
older
that affects
person's
older
disease.
people.
Yes.
And I did see an article. It was published in the Cancer Epidemiology and Biomarkers and Prevention Journal. And what they found was that the incidence of bowel cancer has increased by about 10% over the last 20 years, just across the board. But what they actually found was that it did increase more in younger people and it had decreased in older people. So I guess the interventions and things that have been focused towards older people for such a longer period of time are starting to work. And now it's starting to affect the younger people. Do you know why we would be seeing such an increase like that?
Definitely. So, Bowel Cancer Australia has got a page for younger people, and it's called Never Too Young. So I would encourage anybody that is talking to a patient that has altered bowel motions, and we can talk about the symptoms later, but if there is altered bowel motions or bleeding or mucus or anything, that is a red flag, and they do need to go and get it diagnosed, colonoscopy. Bit difficult in COVID times. There's a 6-month waiting list, and there never used to be. So, this is a major problem. But so there's been a lot of 6-month waiting time.
6 months to get a colonoscopy.
Correct. Yes.
So that's really going to be affecting early intervention then, isn't it?
Absolutely it is. Absolutely it is. So excuse the pun, there's a backup of people waiting. So this is not good. This is not good.
Certainly not.
So the thing is, it's the principles that were found in older populations, such as smoking, drinking alcohol, less physical activity, less plant-based diets, are affecting younger people. And it seems that those over 50 are taking charge of their life in a more appropriate way. So less smoking, less drinking alcohol, more physical activity, more plant-based diets. So it's going in the reverse. And then on top of that, we've got a global rise in obesity driven by, that increased supply of cheap, sweet, energy dense, but low nutrient foods, which is without a doubt a risk factor. And we know tragically that only 5% of the population. So let's flip that for a moment and say 95% of the population do not get their recommended amount of fruit and vegetables.
And that's got to be having
it has a detrimental effect.
Sure.
So it's not really fiber. People think that, fruit and vegetables have a lot of fiber. That's not really the case. Fiber really comes in grains and nuts and seeds, but it's more along the lines of the phytonutrients, the plant chemicals in fruits and vegetables that are protective. So, fruit and vegetable has so many benefits, and it's that we need to be looking at. And I jokingly say to people, look, if you're munching away on 5 serves of vegetables and 2 serves of fruit a day, it's not really time for anything else, So what a fabulous way to eat. Keep everything fresh.
Definitely.
And
organic where possible, do you think?
Oh, definitely organic where possible. And from a genetic perspective, the offspring of obese parents can drive the epigenetic modification of cells, and it's a promoter of altered DNA sequencing. And there's a reduced expression of something called E-cadherin, which is found in the early expression of bowel cancer. And the other thing is there was a meta-analysis of glycemic index and glycemic load on the overall link to human colorectal cancer. So, eating all those sweetie things and foods that raise that glycemic load are definitely have an impact. And there's also a role of the gut bacteria in the etiology of the disease as well.
So you're saying people with dysbiosis have a much higher
possibility
risk
for it, yes. So you can actually, and all of the practitioners will know this, you can do, a bowel screen and find out what sort of bacteria are in the bowel itself. And you'd be looking out for the Bacteroides fragilis, because it can express a toxin which actually targets and cleaves E-cadherin. And it's seen more often in stool samples of patients with colorectal cancer and in biopsies close to a polyp when compared to age-matched controls. So, it's possible that bacteria is capable of epigenetic modification of the gene and the surrounding tissue. There's lots of other pathogenic microbes, but suffice to say, we should be looking after our microbiome. And if you're stuffing your face with high glycemic foods and high glycemic load foods and not enough fruit and vegetables, then, your protective factors go out the window.
The E-cadherin substance that you're talking about, is this something that we can actually test for in clinic, or is it a more specialized?
No, you can't,
test?
But you test for the Bacteroid fragilis, and that's the toxin that, that's the bacteria that expresses a toxin that targets that E-cadherin.
Okay, so you're
targeting it in a way. You're knowing that it's going to affect it because you'll see that bacteria, and it's quite astounding how many people have it.
And is that something that we need to be looking at eliminating from people's guts if it's positive?
Absolutely. So, it depends on which microbiome testing kit you go for. But you will find that one sits in the pathogenic side of bacteria. and it is highly advised to do a proper gut detox protocol if it's found.
I wanted to ask you why bowel cancer is so deadly, because when I was looking at some of the figures, it's actually the second most deadly form of cancer, only second to lung cancer, which I was a little bit surprised about. Can you explain why that's the case? Why is it so deadly?
Yeah, I think one of the main reasons why it's so deadly is that people ignore it. You know, if you get it early, then the survival rates are just amazing. And the cancer survival rates are something like, if you get it really early in stage 1, and that's a localized colon cancer, there's a 90% survival rate. So that means that 90%, actually it's more like 96% of patients will still be around after about 5 years of their initial diagnosis. But people ignore their symptoms, and people think to themselves, well, I don't have a family history. Forget that bit, because there are lots of people who have no family history. It doesn't just apply to bowel cancer. It's also breast cancer and a few other cancers. You don't have to have a family history to get a bowel or breast or prostate cancer. 70% of bowel cancer patients have no family history. So it can happen to anybody. And there aren't very many signs of the disease. And that's another, problem, basically, because unless you've got mucus or blood or alternating bowel motions, you don't really notice it. And it's not associated with pain generally. So, there's a couple of things that I definitely look out for. But, if there's any possibility, or there is a family history, or a person realizes that their diet has not been great, then do a test. I mean, it's not that difficult. You literally, if you do a bowel screen test, it's an immune test rather than the fecal blood test. Because the fecal blood test, you have to, scrape around in your poop 3 times, which is not a lot of fun. But the bowel screen test, all you have to do is wave a little stick around in the water that you pooped in, and you pop it on a little test patch, and you do that twice, and you send it off. And it's a pretty reliable test. So, do a test.
So that might be good for younger people who aren't so keen on getting colonoscopies.
Yeah, that's a good start. But I would say that, there's always a slim chance that it won't pick it up. The only definite way to know is a colonoscopy.
Right. They've actually got to visually inspect the colon.
Yeah. I mean, there is research going on at the moment that is delving much deeper into the various types of bacteria. So I would be thinking in 5 to 10 years, we'll be able to do a poop sample that will say you have the bacteria for possibly progressing to bowel cancer. And there's also some research that's going on, which I'm involved in from the point of view of advocacy, which will test what polyps are cancerous and what polyps possibly will not progress to bowel cancer. So that will cut down the number of screenings. So there's lots going on in this space.
Yeah, it's something that's actually not affected me personally, but when I was probably maybe 18, maybe 19, my best friend actually got diagnosed with bowel cancer, and he was probably maybe a year older than me.
Wow.
And I remember him telling me that the first symptom that he actually got was blood in his stool. And he completely freaked out and went to the doctor. And by that stage, it was actually so advanced that they couldn't save him. And he passed away within months of actually having that blood in his stool. So I guess for someone at that age, no one's really thinking about the fact that they might have bowel cancer. So what we're probably looking at here from a clinical perspective, if we have a young patient or even an older patient coming into the clinic, if there are no signs or symptoms in many cases of this disease, then it's probably not a bad idea for us as naturopaths, nutritionists, allied healthcare professionals to be specifically questioning whether or not our clients have had any recent investigations to rule out bowel cancer.
Absolutely. So, I've had a couple of very young patients, sort of 17, 18 years of age, with alternating bowel problems, pain, let's say on defecation, and maybe just a little bit of mucus. And, mucus is actually a very good first sign, because it can be an early stage. Once you get to blood, then it's pretty much, there's definitely something untoward going on, unless, of course, it's a hemorrhoid or, something, or abscess. But I also have a look at, what's the trend of anemia? Most cancers will express, a chronic low iron studies trending downwards. And that can be a predictive along with the symptoms. And that's really with any cancer: increased reticulocyte counts, low TIBC and transferrin, possibly low hemoglobin or MCV and MCH, low lymphocytes and total white blood cells, and also a low serum albumin. And if you see that, and if blood levels do not change after you've been supplementing and, improving gastrointestinal function, then refer on.
They're great points, actually, because most clinicians would have access to that information, and they might actually be able to, based on what you've said, now be able to potentially identify something before it becomes advanced.
Yeah, so I've got a book on my desk, Dan, and it's an old one, and you probably know this one. It's the Weatherby, Dickon Weatherby, ND, yes, and Scott Ferguson. Yeah, that is absolutely, every practitioner should have that book on their desk, because it gives you tips like that. It tells you what to look for. So, it's a great book.
It is a good text. I am familiar with it, yeah. I was going to mention, just in relation to all those things you said, probably, I would say close to a year ago now, I had a low hemoglobin count. I had blood in my stool, and I was completely freaking out because I had anemia, and I was thinking that there might be something serious going on. But I did the stool sample testing, and I had a colonoscopy and endoscopy, and nothing was found, no hemorrhoids, polyps, anything in there. So that was a bit of a relief for me. Do you know why people might get blood in their stool if there is an absence of something like cancer? What else can potentially cause that?
Well, I find it hard to believe that nothing was found unless, you had something inflammatory and it miraculously went away because you treated yourself, because, blood is a sign of inflammation and or diverticular is a possibility. You can definitely get bleeding from diverticular disease. and a flare-up of diverticulitis. I forgot to mention that one. And you can get blood from hemorrhoids, and you can get blood from proctitis, you can get blood from ulcerative colitis and Crohn's. So I find it hard to believe there was nothing. So yeah, it's an interesting concept. I cannot think of any other reason why you would just have blood in the bowel and nothing there. That sounds very strange.
It was interesting. Everything's sort of normalized now, which is good.
Fantastic.
But I guess for me, it was a bit of a wake-up call in regards to
taking care of your health.
Exactly. Really put a bit of a spanner in the works with everything that I was doing, and really made me look at my diet and lifestyle a lot more closely. Not that I was eating poorly or anything like that, but it does make you think about what you're putting in your mouth and what it's doing to your insides.
Absolutely.
Now, with bowel cancer, the treatments are still really focused around surgery. Are they doing much chemotherapy or are they doing radiotherapy for any of those types of diseases?
Yes, they definitely do. So it depends on where the tumour is, and it depends on the size of the tumour. So if you've got a very large tumour lower down in the bowel, then usually radiotherapy is first, and possibly chemotherapy. Shrink the tumour and then do the surgery, because if you have to take out a large tumour, then the surgery is more traumatic. And chemotherapy is not. Look, they are definitely still using chemotherapy, but not as much as before. So, there are some possibilities that people with, let's say, stage 2 and stage 1 are not having chemotherapy, whereas prior to that, they might have been. So things are definitely changing, and they're getting much better at surgery.
In relation to trying to prevent someone actually ever having to get to that stage, what things can people do? Obviously, a high fiber diet is beneficial, but are there any other things that people can do to minimize their risk? You did mention staying away from alcohol and cigarettes earlier as well.
Yes, so alcohol and cigarettes. Smoking is a risk factor. And alcohol is definitely a risk factor. And I have noticed that there have been some advertisements on the TV, talking about the fact that basically, during this COVID time, people are drinking a lot of alcohol. And, just to put that into perspective, really, women should only have 150 mils of wine, just one. And most people don't do that. And, for men, it's 2. And you are supposed to have a couple of days off a week. Because alcohol does change the way that the tissue in the colon acts, and it is one of the major factors involved in it. Keeping a healthy weight, and particularly lowering central adiposity, so tummy weight. And where does that come in? Well, we often call that tummy weight either the cortisol belt, which means you need to look at the stress in your life, and or it's a carb belt, so eating too much of the high glycemic foods, etc. Garlic is an excellent anti-pathogenic nutrient, so there's some evidence to suggest that eating garlic, just a clove a day, is beneficial. There is no doubt that, when it comes to eating lots of sugar, that will support pathogenic bacteria. And, you do need to look at environmental factors. So persistent organic pollutants, as an example, can sort of, drive, if you like, epigenetic changes. You can also sort of do a genetic profile as well. So some companies in the United States do something called Nutrigenomics, which tells you what sort of foods to eat for your particular gene patterning. And I'm hoping that will take off in Australia fairly quickly. And then, looking at methylation pathways, because we know about how methylation and folic acid can drive certain types of cancers. So definitely be looking at that. Did that answer the question?
It did. It actually did.
Okay.
And you answered it very well. One thing that was going through my mind as you were listing off some of those things was, what about prescription medications? Do things like proton pump inhibitors or anti-acid medications, or even things like antibiotics, do you know if there's any evidence out there to suggest that the use of those medications might increase your risk?
Specifically to bowel cancer, I've got to say it's not something I've really looked into, but it's something that in general practice I'm always aware of. So a while back, I did a podcast on the detrimental effects of proton pump inhibitors. And how it affects the gut. And there was one lovely statement by some researcher who said something along the lines of, whichever way we tried to cut it, there was no doubt that there was an increased risk of death with proton pump inhibitors. And don't take my word for that one, because it is in research. And if you want me to find that paper, I will. So without a doubt, it's not something that we should be, or anybody should be taking long term. In terms of antibiotics, well, that's a given as far as I'm concerned, because if you disrupt the microbiome and you don't normalize it as best you can, then you lead the way for pathogenic bacteria to occur in the bowel.
Right. So this has just opened up a whole potential realm of possibilities here now for patients, because you might have patients with, say, chronic recurrent urinary tract infections who are taking repeated rounds of antibiotics for years and years and years. And that could eventually contribute to some sort of disruption in the intestinal health and potentially lead to an abnormal growth or something in the gut.
Yes, and this is where we're really fortunate, though, because we can do the complete microbiome testing these days. So, that would be something I would look at. And, in terms of the urinary tract infections, actually, it's a chapter I wrote in one of Leah Heckman's books a couple of years ago. With recurrent urinary tract infections, you've got to look at stabilizing the tissue, with your proanthocyanidins, etc. And it's not just about antibiotics, and it's certainly not just about probiotics. It's about getting that boggy tissue to become healthy again.
One thing I remember from speaking with a colleague of mine years ago is that he was really cautious around using glutamine in patients with bowel cancer, because he thought that it could potentially feed the cancer and actually speed up the progression of it. Are you aware of any research in regards to that, or is glutamine actually a beneficial thing to be using?
There's a yes and there's a no in that question.
Okay.
So it sounds like I'm sitting on the fence, but I'm not really, if you listen to what I'm about to say. So in a hypercatabolic disease, which is cancer, there's an increased demand for glutamine. but levels of glutamine were not found to be low in cancer disease itself. However, if you ask me, do I use it? The answer is yes, but only when patients are in active chemotherapy, where you've got catabolic actions from the chemotherapy and hypercatabolic actions from the disease. So I use the integrative swish and swallow approach during therapy, before, during, and after chemotherapy. And if you understand glutamine, it's well known that in times of trauma, the body utilizes higher than normal rates of glutamine compared to glucose in catabolic conditions like recovery from surgery, burns and sepsis, and undernutrition, physical exercise, etc. So glutamine is a potent immune cell boosting amino acid. But if it's not during chemotherapy or chemotherapy has finished, I don't use glutamine.
Yeah, that's a really interesting point there, that you're using it during chemo, because the research articles that I actually found, one was in the BMJ and one was in Nature, they were saying that very much what you're saying here is that glutamine, whilst undertaking chemo, actually provides some pretty potent anti-neoplastic effects, and patients seem to have much better outcomes. It was difficult to actually find anything positive for glutamine when patients weren't using chemo. So it's a really good thing to know.
There is a funny little side note to that. And I don't mean funny, haha, I mean interesting. So the research says that if you've got normal metabolism and you're healthy, then, you're most likely going to have the metabolic pathways that regulate enzymes and make glutamine, and that they're not disrupted. But in order to be, inverted commas, healthy, you have to have a balanced thyroid, balanced growth hormone production, glucocorticoid regulation, and balanced insulin. So I'm pausing there because how many people actually fit in that category?
Well, I was just going to say.
Yeah. It's interesting.
Which patient can tick all those boxes?
Not many. But if you've got, generally a really high quality protein diet, technically you should have enough glutamine if you're, digesting it well. But a bit of a concern for me is the advent of plant protein powders. I'm not a particular fan because they've often got low leucine and high omega-6. And leucine can activate glutamine synthase, and it's not a good thing. So you really need to make sure that whatever plant protein you've got, it has to have some decent amount of leucine in it. And high omega-6 is not a great thing to do, particularly in cancer.
No, and just in relation to the leucine, so you're saying a plant-based protein that has a lot of leucine in it?
Low
leucine.
Yeah.
Okay, yes, that makes sense.
And without leucine, then, we don't activate the glutamine synthase and form the glutamine. So,
right.
Yeah. Yeah. So,
I was
yes during chemo and no as ongoing treatment.
Yes during chemo, no during ongoing. Yeah, that makes sense. And what dose are you using with your glutamine supplementation in people undergoing chemotherapy?
So the glutamine swish that is recommended in integrative forums is 10 grams of glutamine 3 times a day, but I don't find that you need that much. I generally do 1 gram of glutamine 3 times a day. And that seems to be really helpful. It reduces the oral mucositis, and it also helps with, reducing the peripheral nerve damage and protecting the gastrointestinal tract. So I generally go for 1 gram 3 times a day.
Yeah, 10 grams 3 times a day, it's 30 grams. It's a pretty high dose. It is interesting, though. I have seen some recent studies coming out using high-dose glutamine for a range of different conditions. And I was thinking, wow, maybe I've been using glutamine wrong all these years, because it seems like they're using 5, 10, 20, 30, 40 grams every single day for extended periods of time.
Yeah.
But it's interesting to hear that you're still using the lower end of the dose and still getting really good results.
Yes. Yeah, it's been interesting. And, mainly because I've had a lot of pushback from clients who've said, I can't do 10 grams of that stuff. It's costing a fortune, and B, it's pretty awful. And so, we've managed with lower doses, and most people are doing well on the lower dose.
So you say it's a glutamine swish. So what I'm assuming that means is you're dissolving a glutamine powder, just plain glutamine, in some water.
Yes.
And they're swishing that around their mouth. And how long would you hold it in the mouth for, or does that not really matter?
About 30 seconds, and then swallow it.
Okay. Interesting. Good to know. I mean, glutamine is something that I've used for like mucous membrane issues, and I have had patients keep it in their mouth for sort of 30 seconds to a minute, and it does work quite well. So interesting to hear that you're also using something similar.
Yes.
Are there any other, not that you haven't given us so much amazing information already, but are there any other like clinical pearls or words of wisdom that you can give to practitioners who might be either interested in this area, might be treating a client at the moment with bowel cancer, or they may be looking to expand their clinical knowledge?
Yes. So I think a lot of practitioners will resonate with what I'm about to say, and some of it will be new and some of it won't be, but no extra iron, even if the patient has low iron. That's like putting a match to the fire. So avoid it. Even if the iron levels drop to about 80, just don't worry about it. It will come back. Iron will come back. Don't be tempted to supplement iron.
Just in regards to that, sorry, Teresa,
yeah, sure.
You're staying away from iron because it's causing oxidation, or is there another reason for that?
It actually makes cancer cells grow. They love it. They love it. It's like giving them oxygen to grow and spread.
Interesting.
So it is better if a patient has sort of a low iron count whilst they're going through chemotherapy.
That's good to know, because there might be people seeing their patients' iron levels decreasing during that time, and they might actually think that it's a requirement to supplement with iron. Could make things worse. Yeah,
there's lots of good research around that, and lots of integrative knowledge about that from the nutritional oncology people that have done studies on it in the States. So it's something that I didn't know myself, and would have possibly in the past used iron supplements, but certainly I don't anymore. And have a bit of a look at that. Iron in food, not so bad, but don't, there's the old adage, and particularly with bowel cancer, not more than 500 grams of iron food in a week, and certainly don't char grill it.
Yeah, so no more than 500 grams of, say, red meat per week, even in someone who's got bowel cancer?
Absolutely.
Yep. Fantastic.
And so a couple of years ago, I met a very lovely integrative oncologist from New York, and he was talking about vibrational therapies. And I can remember at the time thinking, oh, I don't know about this. But there's a very good TEDx talk by Joanna McEwen. She's a researcher in vibrational studies in the UK. And she talks about the singing bowls. And he was actually mentioning the singing bowls because they do know that every single cell in our body actually vibrates at a certain level. And I think that's why the if you can for long enough, it's a similar sort of vibrational therapy. And laughing is vibrational as well. And it's hard to laugh when you've been diagnosed with something as awful as that. But, there have been cases where people have laughed themselves out of certain diseases. The other thing is that you can't really go wrong with single nutrients when you're looking at treating people when they're going through chemotherapy. When we're looking at herbs, you have to be very careful because a large percentage of herbs obviously increase the CYP enzyme activity. But you can't go wrong with some zinc and B and vitamin D and magnesium, etc. And oncologists are more likely to say yes to minerals and vitamins, but no to herbs because of their antioxidant type profiles. Food as medicine, obviously, grass-fed, organic. Get rid of mold, move out. Mold is, definitely something that you want to be moving away from. I talk to patients about getting rid of anything that smells nice, except for aromatic oils. The phthalates and the cleaning fluids, bleach, terrible stuff. Get genetic profiling done, or, get the profile of the cancer tissue and your genes done. Because there's some interesting work around heat shock therapy if you're sensitive to it, and lots of cancer patients are, and they can use infrared treatment. Check out methylation and detoxification genetics, complete microbiome testing, Nutrigenomics, which is growing and can't wait for it to get here. And just remember that, and this is an important fact, cancer gets used to the same protocol. So after every round of chemotherapy, it's very smart and it may change its pathways. So it can mutate, take different growth pathways. Consider pulsing your supplements, a couple of weeks on, a couple of weeks off, and swapping them around. And retest after you've been given an all clear, because you just want to make sure that there aren't any more circulating tumors. And most importantly, treat the whole body with mind, body, spirit. Much more important than I think we've ever given it credit for. If somebody doesn't want to be on the planet, it won't matter how much supplements you throw at them, or how much good food, or how much chemotherapy or radiation or any of those sorts of things. They won't want to be here.
Fantastic advice, Teresa. I have learnt so much in the last hour.
Awesome.
You are a wealth of knowledge. Thank you so much for giving us your time today. I really appreciate it.
You're very welcome. And I hope there's some clinical pearls in there for everybody.
Oh, there very much so is. Teresa, before you leave us today, if people are looking to get in contact with you, or they are looking to refer a client to you, where can they find more information or your contact details?
Yes, so I'm at the Burke Street Clinic, which is in Surrey Hills, so they can always ring the Burke Street Clinic. which is in Sydney, 0293320400. And I can also be contacted through Bowel Cancer Australia Nutritionist, which is, the website is Bowel Cancer Australia, all one word, all lowercase, .org.
Thank you so much, Teresa. Really appreciate your time, and I look forward to chatting again with you soon.
Thank you.
Thanks for tuning in. We hope you enjoyed the show. If you have any questions or comments, head on over to humanley.com/podcast and join the discussion. Make sure to follow us on Facebook and become part of our growing community of like-minded health professionals. Until next time.